state body, the Tamil Nadu Orthopaedic Association today. I am Dr. Ashish Phadnis, and along with Dr. Abhijit, I'll be the coordinator for this meeting. And I would like to welcome our dignitaries who are taking part in this webinar today. I would like to welcome our Honorable Vice President of the IOA, Dr. Chadda. I would like to welcome the President of the West Zone of the Indian Orthopaedic Association, Dr. Ajit Shinde. Dr. Naveen Thakkar, the Secretary of the IOA, will join us soon. The President of the Tamil Nadu Orthopaedic Association, Dr. Vanasekhar, a very warm welcome to you, sir. And my dear friends and colleagues on the panel, Dr. Muthu Bayaladurai, Dr. Ramesh Perumal, Dr. Kirubakaran Pattabiraman, Dr. Ashok Sham from Ortho TV, and Poonam from Ortho TV will be with us. Dr. Devendra will be joining us in some time, and me along with Dr. Abhijit will start the proceedings. To start the proceedings, I would like to welcome Professor Dr. Ajit Shinde, the President of the West Zone of the Indian Orthopaedic Association, to kindly welcome everyone and start the proceedings for the day. Over to you, sir.
Thank you, Ashish. Vice President of IOA, Dr. Chadda, Secretary Dr. Naveen Thakkar, my team members of West Zone Indian Orthopaedic Association, Dr. Vikas Jain, Vice President, Dr. Shivanand Bandekar, Second Vice President, and President Secretary of Maharashtra and Gujarat Orthopaedic Association, Dr. Vasudev Gadegune, Dr. Narayan Karne, Dr. Govind Purohit, and Dr. Kamlesh Devmaradi, and all respected faculty members. Good evening and welcome to third webinar of West Zone of IOA. Today we have Tamil Nadu Orthopaedic Association with us. I welcome President Dr. Vanasekhar Palani and Secretary Dr. C.J. Ravi. I thank you for your support and participation in today's CME. We have already talked about injuries around knee and hip joint. Today we will be dealing with open injuries. Open injuries is a challenging issue for every orthopedic and trauma surgeon. As we know, outcome of these injuries, if not managed well, can land the patient in great trouble. So it is very essential to cater the every small details of management of these injuries. Even though there are great advances in various techniques such as VAG dressing, use of stimulant, it is very essential to understand basic principle of managing the injuries. We have excellent panel to discuss the issue with Dr. Ramesh Perumal, Dr. Devendra, both from Ganga Hospital, Coimbatore, Dr. Kirubakaran from Pondicherry, and Dr. Mithu Malaidurai. I am sure this is going to be an interesting discussion with our moderators, Dr. Abhishek Kale and Ashish Phadnis, who are eminent surgeons and esteemed faculty with wide experience. Thank you, Abhijit and Abhishek, for well organizing and coordinating the session, and thank you Ortho TV for their collaboration. Thank you everyone. Thank you Dr. Chadda sir.
Thank you very much, sir. And now we would like to know about the road ahead, and Dr. Chadda is going to take us through the road ahead for the IOA, who is the Vice President of the Indian Orthopaedic Association. Dear sir, a very warm welcome. We look forward to hearing from you.
Good evening, everybody. Professor Ajit Shinde, past President of the MOA, Organizing Chairman of the recently concluded IOCON 2021, my senior, my mentor and dear friend, esteemed guests from Tamil Nadu, Professor Vanasekhar, Dr. Raju, and my friends from Ganga Hospital. I am very, very happy to be here today for three reasons. One, I am sitting in the company of two of the largest orthopedic state chapters, which is Tamil Nadu and Maharashtra, and where a new zone has recently evolved, which is the West Zone, which is going to comprise, besides Maharashtra, Gujarat, as well as Goa. And we are happy to have all these states together represented, and would be one of the 5 zonal chapters at the IOA. Why am I exceptionally happy? As I said, there are 3 reasons. One, Maharashtra and Tamil Nadu are the only 2 states that I'd ever practiced orthopedics in, because I worked at the MIOT hospitals in Tamil Nadu, in Chennai, in the year 94, 95, and 96. And I've been in and out of Mumbai before and after that. So these are 2 state chapters that I have belonged to a certain extent. Next, today the discussion is on open injuries. I was an open injury surgeon from Sion Hospital. I had done mainly trauma, and it's Madras or Chennai which made me into a spine surgeon. So a lot of things come together. And above all, right from the days of Gustilo Anderson to the days of Harold Charney and Goetzen to the Ganga score today, we have evolved over management of open injuries. And which other 2 states besides Tamil Nadu and Maharashtra to be coming together, and the entire West Zone, where probably the highest number of these open injuries are seen, despite a huge amount of road traffic control being done in Tamil Nadu. I still believe that there is a large number of open injuries seen there, as well as the ones in the state of Maharashtra, Gujarat, and Goa. Hence, it is actually the time to look at our presidential theme, where we are going to look at both surgical skills and soft skills, and we need to practice both. One, open injuries are those places where our decision making and our surgical execution are very, very important, but also the soft skills of how to handle everything from the patient, from the person who brought him, to the Good Samaritan, to probably the police, and the long-term rehab, and even the disability that he or she may sustain in the long run. This has to be looked at as a much larger picture. And as we discuss not just management of open injuries, but how to take care of the disability and to make these open injury patients less disability or disability free in the future, should be the way we look at such discussions as of today. It is indeed a pleasure and an honor and a privilege to be here. And I would be happy if all of you can put your minds together and probably create the path forward as to how such injuries should be handled in our country and all over in all the states. So have a great, fruitful discussion. Let's practice safe surgery, which is not just surgical skills, but soft skills as well. Thank you for inviting me. Thank you and have a great time. Thank you so much.
Thank you very much, sir. Thank you. And now it puts the webinar into right perspective. I had never realized that we are the largest 2 state chapters of the IOA, and these 2 states and these 2 zones will be very close to your heart for obvious reasons. So at the outset, let me invite Dr. Ajit Shinde. Our Professor Dr. Ajit Shinde is the President of the West Zone of the Indian Orthopaedic Association, and he'll be talking to us on management of complex grade 3 injuries, the what, the how, and the when of it.
Ashish, I think there is one talk from the President Vanasekhar regarding the
Yes, sir. I'm so sorry, sir.
introduction to the webinar, Dr. Vanasekhar.
Yes, sir.
Yes, sir.
Dr. Vanasekhar, welcome, sir.
Yeah. Good evening, sir. Respected President West Zone Dr. Ashish Phadnis and leaders of West Zone Indian Orthopaedic Association, Vice President Dr. Chadda, IOA, Secretary Dr. Naveen Takara, and the leaders of Indian Orthopaedic Association, President Secretary of Maharashtra Orthopaedic Association and Gujarat Orthopaedic Association, and the coordinators, respected faculty members. Thank you very much for giving me a chance to be here in this evening. So thank you very much. wonderful topic, compound fractures, which is the commonest surgery nowadays. And I can remember that one of my one mentor and come friend, Dr. Ashish Phadnis, in one of the conferences, TraumaCon, when somebody asked him about fellowship training abroad, he said, average number of compound fractures seen in UK is less than 1. But in India, per day, it is more than 2. So the time has come where the foreign people has to come to India for getting training. So that is the standard set up by our leaders in orthopedics, our teachers. And I'm happy that the youngsters and the teachers are very much interested in learning as well as teaching the juniors the orthopedic knowledge they have gained. So I'm happy that Indian Orthopaedic Association and various chapters are conducting so many programs for teaching so that the youngsters are getting trained very well. And the theme for Tamil Nadu, President's theme for Tamil Nadu is get it right the first time. Like that, our people are getting more chances for getting trained by CME programs for physical or in vitro, and they got cadaveric workshops also. So I wish the CME will be a great success and it will be definitely useful to the juniors. And with the great enthusiasm and training by our teachers and the active association activities and the leaders in Indian Orthopaedic Association and various chapters, I'm sure that Indian orthopedics will be topping the list internationally, and wish you all the best. I wish the young surgeons and postgraduates a bright and successful career. Thank you. Thanks once again for giving me a chance.
Thank you, Vanasekhar sir. Thank you very much.
Thank you very much, sir. Thank you very much for that. And I'm sure this webinar would be doing well with the blessings of you and Chadda sir. Now we'll begin the webinar by inviting Professor Dr. Ajit Shinde, the President of the West Zone of the Indian Orthopaedic Association, to give the first talk on the management of complex grade 3 open injuries, the when, what, and the how of it. I welcome Dr. Ajit Shinde, sir.
Yes. Yes, my screen is visible.
Yes, sir.
Yes, today my topic is management of grade 3 open injuries. How, when, and what. Compound fracture, commonly termed as an open fracture, is osseous disruption in which breach in continuity of skin and soft tissue communicate directly with fracture and its hematoma. Comparing with the US and European data, as mentioned by President Vanasekhar sir, there are more than 4.5 million cases of open fracture occurring every year in India. This is a Gustello-Anderson classification, which is most widely used based on size of the wound, soft tissue damage, periosteal and vascular injury. But it does not help for decision making. Hence, injury severity score, which is developed by Ganga Hospital and which is based on 4 parameters, and points are given according to severity, and whenever score is more than 14, it is a highly predictive of amputation. Antibiotic plays very important role in the management of open injuries. We follow this regime for the management. The first and foremost step under antibiotic cover is a thorough debridement. Right from skin to bone, all dead, devitalized tissue has to be excised. Compartment to be released. Remember, the first debridement is your best chance for prevention of infection. After debridement or during debridement, irrigation plays important role as it reduces the bacterial load. We prefer normal saline for wound irrigation, no adjuvant with low, medium pressure lavage system, and follow rule of 3. We prefer in managing open injuries early stabilization. Advantage of early stabilization, it protects soft tissue, prevent further damage, restores the bony limb length, reduce soft tissue dead space and thus wound infection, facilitate patients' early return to normal function. The choice of implant depends upon bone fracture and its location. Extent of soft tissue injury, degree of contamination, and physiological status of patient. Similarly, we prefer early cover of the wound, preferably within 48 to 72 hours, which decreases incidence of infection and non-union. Delayed closure methods such as skin grafting, flaps are prepared as per situation, size, and location of the defect. Wax dressing reduces local edema, enhances granulation tissue formation, and obviating frequently need for plastic surgery procedures. Now, what I have done? This is my first case. Young patient, IT engineer, road traffic accident, segmental tibia fracture with open wound. Initially, after debridement, stabilized with IOA external fixator, and in second stage, flap cover surgery was done and finally managed with tibia interlocking nailing. This is his 18-year follow-up, clinical and radiological. This is his function. This is my second patient, 50-year male veterinary doctor, road traffic accident on National Highway, grade 3B segmental compound tibia fracture with tibial bone loss of 15 centimeter, had been advised amputation elsewhere. This is his clinical pictures and X-ray. Decided to manage with Elizarov. We did and bone transport. After debridement and freshening of the ends, distal corticotomy was done and internal bone transport has been started. This is his 14-month follow-ups and we achieve bone transport union. This is his 13 years follow-up, clinical and radiological. This is his function. This is my third case, presented with open fracture, 22-year young male, open knee injury, fracture lateral condyle of the femur, fracture patella, fracture proximal tibia. After debridement, all fractures stabilized with minimal invasive surgery, cannulated screw, tension band wiring, and Elizarov. In second stage, the open wound covered with the flap. And this is 4-year follow-up, clinical and radiological. And this is his function. This is my fourth patient, 17-year male, road traffic accident, grade 3C injury, wound over posterior aspect of the knee, dorsalis pedis not palpable. Patient was having ipsilateral distal femur and proximal tibia fracture. This is his clinical and radiological pictures. The injury confirmed by CT angiography. Fortunately, he was not having any internal injury to the vessel. So immediately after debridement, both the fractures stabilized with the joint spanning external fixator, and open joint and bone was covered with the flap in same setting. And finally, the fracture femur distal stabilized with the interlocking nailing and proximal tibia with the cannulated cancellous screw. And this is his 2-year follow-up, clinical and radiological. And this is his function. As mentioned, Gustilo-Anderson classification many times does not help for the decision making. Though this patient was having grade 1 injury, because of severe soft tissue injury, there was severe swelling and distal pulsation was not palpable. It is one of the emergency, limb-saving emergency. One should do immediate fasciotomy. We did same and got the distal pulsation. Fracture stabilized with the Elizara ring fixator. Fasciotomies were covered by skin grafting in second setting. This is his 17-year follow-up. Also, he required second surgery, third surgery of bone grafting as there was open injury and loss of the bones. This is his function. This is my last case, 45-year police officer, road traffic side sweep injury, multiple open upper limb injuries, stabilized primarily at local hospital with external fixator of humerus, radius, and intramedullary nailing of ulna. Presented after a week with the infection and necrosis of soft tissue of arm and forearm. Managed with debridements, VAC, and application of VAC application and skin grafting. After skin coverage, as the skin condition was constrained, all the fractures stabilized with the minimal invasive surgery nailing. This is her follow-up. For delayed union of distal femur, we required additional surgery of the humerus. We required one more surgery of plate osteosynthesis and bone grafting. And this is her function. In conclusion, for both better prognosis, adequate and satisfactory debridement by experienced surgical team in major OT with appropriate instrumentation and implant is preferred. Enough plenty saline irrigation with prompt systemic IV antibiotic along with fresh antibiotic bead locally prophylaxis, reduce infection and non-union. Early stabilization and wound coverage with judicial use of back dressing and appropriate definitive osteosynthesis is essential for base functional result and to reduce the disabilities. As we know, in open injury, there are more chances of the disability. Thank you very much.
Thank you very much, sir. And Dr. Jayaraman has also joined us. And welcome, Dr. Jayaraman, who is the Honorary Secretary of the Tamil Nadu Orthopaedic Association. Excellent presentation, sir. I think we'll move on to the next presentation as there are no questions in the chat box either. Amongst the panelists, if anyone has any questions, I can take them. Otherwise, we'll move on the next talk to Dr. Ramesh Perumal from Ganga Hospital, who is going to talk to us from the open injuries, the transit from the casualty to the operation theatre. The most important step as to what we do when we see the patient for the first time, and what happens next before he is taken up for a definitive treatment. Welcome, Dr. Ramesh.
My screen is visible, sir.
Yes, sir. Yes, sir.
Good evening to all of you. My sincere thanks for the IOA for the opportunity, and greetings to the President-elect of IOA, West Zone IOA President, the TNOA President and Secretary, and the organizers and my co-faculty members. Warm greetings from Ganga Hospital. My talk is focused on open injuries from casualty to operation theatre. As you all know, the treatment starts from the injured site. When you see all the open fractures are often very high energy injuries. So there's the approach described as a scoop and run approach. When you take an ice cream, you just scoop and take the ice cream. So in the same way, in the scoop and run approaches, it is very mandatory because most of these injuries are associated with other systemic injuries. So it is very well important to take the patient as soon as in the accident site and is reaching a nearby hospital is one of the most important initial treatment in all these injuries. Because as you all know, the initial golden hour, the platinum 10 minutes is very important in polytrauma with an open injury for an aggressive resuscitation to save the life first. It is better to take the nearby trauma care center. It is better if it is reaches a nearby tertiary trauma care center where all the facilities are available and the team of surgeons are run, the intensivists are ready to resuscitate the patient. And WHO has predicted the future bodily injuries are predicted to outpace all the infectious disease in worldwide in terms of years of productive life is lost. And also in the top 10 global causes of death, the road traffic accident is coming in the number 7. Apart from the systemic diseases, road traffic injury is of a serious concern as many times it might end up in loss of life. Hence, the management of open injuries has to be dealt very seriously. And as you all know, when this patient comes to the emergency department from the peripheral center, so our main thing are the patient factors. It depends upon the age and the obesity and also functional demand of the patient and also the level of osteoporosis. Definitely, the people who have got an elderly age group has got a low functional demand and presence of osteoporosis. The treatment might get delayed or the other comorbid factors can complicate the treatment. The other comorbid factors are the medical illness. People who are uncontrolled diabetes are more prone to develop infection, and people who have got a serious systemic illness like an ischemic cortisone blood thinners. The repeated surgeries might cause little harmful effect to his life. People who have got chronic kidney disease and a history of smoking, there is an inflammation is going to take place and the immunity is low, the chance of infection are going to be high. And per se, coming to the injury factors, the severity of injury, the loss of the skin, the musculotendinous units, and the loss of bone, and presence of an ipsilateral other injuries like other polytrauma are going to make a big impact in the outcome. Hence, all these factors have to be considered in the management of these open injuries. So, evaluation of open injury management is got many eras. The eras of life to preservation, it was coined in 16th century by Ambrose Paré. At the point of time, the cleaning of the wounds and the removal of necrotic foreign bodies, necrotic tissues were done, and the main aim is to do an amputation to save the life, because the chances of infection were very high at that point of time, because antibiotics were not invented at that time. The second era is era of limb preservation. So in the 18th century, Desaulles coined the term debridement. It means removal of the necrotic tissues and also the foreign bodies. The term resuscitation was coined at that point of time, where patient has lost a lot amount of blood, so it needs a good amount of replacing the volume which he has lost. And further, the bony part is assessed by the skeletal stabilization. So the fractures have been stabilized with an external fixator at that point of time, and followed by soft tissue cover was the base of limb preservation era. Now the next era is the era of infection prevention. So where the debridement was taken into the Godina approach, where there's an aggressive debridement was done and the antibiotics are invented. So the penicillin group of antibiotics were given to prevent the infection of the open fractures. Now we have come to the last era of functional restoration, where we are beyond the aggressive debridement. We are looking for an early soft tissue cover and also definitive skeletal stabilization, where we can nail or the plate fixation as a definitive management is being done. And also the open injuries have been evaluated at the level of molecular level. So by assessing the levels of serum lactate, look for the level of hypoperfusion of the particular region, and also the serum interleukin 6. The inflammatory markers, when the inflammatory markers are high, we have to delay the procedures, second stage procedures. When the inflammatory markers are at lower level, the definitive fixation can be planned. So these are all the eras of open injury management. As you all see, the pathophysiology of open fractures, it happens 11 in 1 lakh. When compared to the Western standard, it happens 1 to 2 per in 1 lakh persons. But in India, it is much high because of the road traffic injuries. It is very high in developing countries like India, where the traffic accidents are very high. And also the diaphyseal fractures are common. So when we have a Ganga Hospital, the tertiary trauma center, we treat approximately 1,500 to 1,800 patients in a year. So in this chart, you can see the group of open fractures as per the region. Around 50% of the fractures happens in the tibia. So the tibial fractures were very commonly injured. That's why the Ganga Hospital score evolved based on the spectrum of injuries that happen in open tibial fractures. So once the patient has come from the accident site, from the emergency room. So the main concern is about the hemodynamic instability, the first concern. As per the ATLS protocol, our aim is main focus on the hemodynamic instability. When you suspect a pelvic injury, we always give a pelvic binder or a circumferential sheet in the emergency room itself. And also we just cover the wound with the dressing, and also we splint the limb. These are all the initial measures. And we look for the hemodynamic instability. Here you can see the patient has got an high pulse rate. It indicates an hypovolemic shock. So all this, the assessment of this injury, it starts from the ATLS protocol. The treatment starts at the emergency room itself. So when the decisions have been taken after the assessment, it reduces the mortality, and decision making can be easily possible. Resuscitation has been described as a massive or a damage control resuscitation. In the damage control resuscitation, it includes 3 components. One is the achieve a permissive hypotension, where you maintain the systolic blood pressure between 80 to 90. It maintains the end organ perfusion and the mean arterial pressure. Where the initial point where there's a massive resuscitation aims at raising the systolic blood pressure to normal, it causes the pop the clot phenomenon, where the patient might bleed more. So that's why the term is coined as a damage control resuscitation, where you maintain the systolic blood pressure of around 80 to 90 millimeters of mercury. And we give a hemostatic resuscitation in the point of blood products. In the blood products, where blood and blood products are given, where the dilutional coagulopathy, the triad of the dilution disorders have been addressed. And the damage control orthopedics comes in the form of a skeletal stabilization, where you give an external fixator, or depending upon severity of the open injury, we can plan for the fixation. So damage control surgery is also a part of resuscitation. Hence, in the initial point of time, the optimal fluid for resuscitation has been debated over a period of time from isotonic saline and ringer lactate. What we commonly give is we give an isotonic saline or a ringer lactate. In the initial 8 years protocol, it was given as to 2 liters as the initial fluid. Now it has been reduced to 1 liter. And then it is followed by the blood products. It has been given in 1:1:1 ratio, where you give a first unit of packed red blood cells, followed by the fresh frozen plasma and also the platelets. And whole blood is very useful, but it causes hypothermia and acidosis in massive blood transfusion. Particularly the whole blood is, if it is a fresh blood, it is good. Many times if fresh blood is not available, it is better to give a blood products. And tranexamic acid is useful in polytrauma with open injuries, but it has to be given within 3 hours of injury. So the other very important thing is documentation is very important. History about the accident, where the incident has happened near the farmyard or some sort of at the end of the road, when you suspect the contamination or the sewage or the farmyard contamination is very important to document. And also other this treatment at the pre-hospital phase. So where any local treatment was given in the nearby hospital, any antibiotics was given or any tetanus toxin injection was given, is a very important document. And it is very important to identify what happened to the accompanying persons. Somebody, if you go in a two-wheeler, the one might be died on the spot. It shows the severity of the injury. So this patient might having a polytrauma or severe other systemic injuries. And it's very important to look for the comorbid factors, the history of the systemic illness, whether the patient is on any blood thinner drugs or any other serious kidney injuries or other part of when the patient is on immunosuppressive drugs. Or these are all the very important documentation at the emergency room itself. Next, coming to the examination, it is very important to have a proper exposure because of the moral lesions of the thigh or in the abdomen might be concealed if the patient is not exposed properly. So it is very important to expose the patient properly, and also it is very important to cover the patient to prevent hypothermia. And grossly deformed and short limbs, if you can see the puckered skin with a grossly displaced supracondylar fracture, it needs a good amount of splinting, as it might cause the neural and vascular structures might get compromised. So, and also it is very important to look for the documentation of the distal pulse and the neurology. Many times it may not be possible to do a toe movements or a finger movements because patient will be in much of agony. But also it is very easy to look for the sensation in the tips of the fingers or the toes. So say in the sensory loss is there, then there is a definite evidence of a neurological involvement. And also the proportion of pain is also very important to look for a compartment syndrome. So the most important thing is the size and severity of the wound, but many times the size and severity does not show the severity. There may be a small punctured wound in the skin, but if you take an X-ray, there will be a shattered diaphyseal or metatarsus fractures, which may see the severity of the injury. And if it is a bigger wound, then you have to document it, that one also. And you have to have a good amount of good quality of photograph has to be taken in the emergency room itself. We have the camera in the emergency room itself. We document the photographs in the emergency room itself. And also we take to the patient once the painting and draping has been, we also take a good quality of photograph in the operating room itself. The photographic documentation is very important because once the procedure is done, the nearby, the close family friends are going to come in the next day. So it is very important we have in the file, we give them a file about the arrival status of the open injury photos and also what all the treatment flaps have been done, primary approach, and we give a series of photographs to the patient attendants so that they could come to see the severity of injury and also they see the stages of treatment has been done. So in the emergency room, it is important to do a sterile dressing to seal the wound. And also it is very important, it should not keep on opening the wound. So you take the wound picture and seal the wound, and we have the WhatsApp group in the department of the unit who is treating, then the photo will be added to the group. So that each and every time in the emergency room or also in the preoperative room and everything, we should not keep on opening the dressings. So we see the dressing, when the consultant comes, at the final thing, they open and see the wound, and then we call the attendants, we show the wound, and then we discuss about the treatment options. So in a patient of a very much bleeding wound, the compression dressing can be done In case of an hypotension with the bleeding wound, you can inflate the tourniquet in the emergency room itself, but it is very, very important to document the time where the tourniquet was applied in the emergency room. As the tourniquet time is increasing up, then you have to be in a hurry up to take him to the theater immediately, and then you have to deflate the tourniquet, you look for the bleeding sources. And the blind clamping should never be done in an emergency room. Because of a clamping, it might cause an injury to the neighboring neurostructures or the neighboring venae committents. When the bleeding artery, you might be injuring the venae committents on the nearby side or the injuring nerves in the nearby side. So when there is a bleeding wound, it is very important to give a compression dressing and elevation of the limb. If it is much more bleeding, then you can apply the tourniquet in the emergency room itself. The main thing, signs of vascular injury are the hard signs and also the soft signs. The hard signs are absence or a significant difference in pulse on both the sides, in presence of a severe bleeding and expanding hematoma of the affected region. But the other signs are associated neurological deficit should be looked for, and altered temperature and also delay in the capillary fills are the other things. And the absence of pulse oximetry is also one of the signs to look for a vascular injury. So compression dressing and splinting the fracture, and then you have to re-evaluate for the vascularity. Once you do the splinting the fracture, probably the compression may be released and you can be able to feel the vascularity at the distal level. Following a splinting, if you're not able to feel the pulse, then you have to look for a hand Doppler, which is available in the emergency room itself. So you can look for the Doppler signals, the type of block, and also if time is available, you can shift them to the CT angio and look for the at what level the vessels were injured. But depends upon the infrastructure, and it might require a contrast. People who have got an elderly age group with the creatinine level has not done, CT angio is a relative contraindication. A neurological examination is very important. Look for compartment syndrome. Motor functions are difficult because they're having in pain. So the sensory thing and the touch and pinprick testing is possible in particular autonomous zone, which is a part of a compartment syndrome. The role of cultures in the emergency has been described for many, many years. As you all know, the infection in open injuries is a major threat, but there has been a poor correlation between the positive cultures and the clinical infections, because the most of the infections happen in the hospital environment. So the hospital bugs are the commonest source for infection. We have also done our study in open fractures, the role of cultures. The cultures are taken before debridement, after debridement, but the correlation was not significant. Hence, it mainly requires a good amount of debridement is very important. And the fifth point is antibiotics. The role of antibiotics in open fractures is not prophylactic, but it is a therapeutic. It has to be given as early as possible. So in our emergency room itself, once the open fractures come, we ask for any history of a kidney problem. So otherwise, we give cefuroxime injections, 1.5 grams straight away following a test dose in the emergency room itself. People who are having an grade 3 or the other severe injuries, we have to add an amikacin injection, but we give an amikacin injection based on its creatinine levels. It depends upon institutional experience. In the presence of an organic and sewage contamination, it is better to add a metronidazole. Look for the anaerobic organisms. And tetanus toxoid is given in all farmyard injuries. So our Ganga Hospital antibiotic guidelines include cefuroxime of 1.5 gram IV 8th hourly until first debridement. After the first debridement, cephalosporin and gentamicin is continued until the soft tissue closure, or it is 72 hours. The metronidazole is added in farmyard injuries. When a patient is allergic to cefuroxime or the penicillins, we add a clindamycin 600 mg IV 6th hourly in patients who are allergic to penicillin. So the current practice guidelines based on the systemic survey of the antibiotic prophylaxis, they advise early systemic prophylaxis up to 2 to 3 days, but depends upon the institutional experience. We used to give it for 3 days, but as per based on the Ganga Hospital score, depending upon the severity of injury, our antibiotic protocol might extend a bit late, and also based on the other systemic illnesses. So the next thing is, seventh thing is that the trauma series of X-rays, we have to take a good amount of APN lateral view, which should show the joint above and below is very important. You can see the open supracondylar fracture femur. The above is the X-ray pelvis showed a dislocated hip. So it is very important to screen the joint above and below. And also you have to look for the gas shadows or evidence of foreign bodies in the X-ray itself, which shows the amount of contamination, the chance of gas gagging are very high. It needs an aggressive debridement and needs removal of all foreign bodies. And we should make a mention that there should not be any multiple shifting the patient to an X-rays and shifting the patient to the lab and shifting the patient to CT scan. It has to be avoided as much as possible. And the other important regions are taking an X-ray pelvis, chest, and cervical spine laterally to look for the evidence of polytrauma or other systemic injuries. And in articular fractures, if the patient is hemodynamically stable, we can do an CT imaging for a better quality of the joint orientation, where a debridement and articular reconstruction is the main concern in the better outcome. And also when you suspect a polytrauma, the whole body CT is very important, but it has been recognized as a tunnel of death in unstable injury because the patient might have an hypovolemic shock in the CT room itself. Hence, the whole body CT or selective CT, you have to be very careful. An unstable patient has to go to OT, but not to the CT. This has been mentioned in many lectures. And 30% of injuries can be missed in selective CT. Hence, it is advisable to do a whole body CT, as it reduces the mortality rate, as a definitive source can be identified in the most of the patients, because we are doing a contrast whole body CT and reduces the additional procedure of when compared to the selective CT. And the ninth point is you have to look for the associated injuries. They are very important in the outcome in open injuries. Where look for the head injuries and thoracic injuries and the bowel injuries, and also in the open pelvic fractures. These are all the direct dependent factors for mortality and morbidity. This is an example of open distal femur and open pelvic injury in the polytrauma patient. Whole body CT identified a bowel injury and a presacral hematoma and a frontal bone fractures. Hence, it required a good amount of damage control orthopedics and also damage control resuscitation. Further, the last point is the role of biochemical markers in open injuries. As you see the era of functional restoration, we go beyond the open injuries at the molecular level to look for the humoral and cellular mechanism involved, and also the multi-organ syndrome and mortality are directly correlated with the systemic inflammatory syndrome, where the current thing is mainly focused on serum lactate at the interleukin 6. When you take the serum lactate, the normal levels are less than 2.5. It gives a direct measure of hypoperfusion and anaerobic metabolism. Hence, the patients are more prone to develop a multi-organ dysfunction syndrome when the lactates are not corrected at appropriate intervals. The other thing is the inflammatory marker serum interleukin 6. The levels are less than 200. When the levels are high, the inflammatory markers are very high. The chance of getting a second hit phenomenon, or patient is going into the immune cascade is going to be very much affected. Hence, you have to delay the second stage surgery once the interleukin levels have come down to normal. The other thing is C-reactive when they are high, it is also the inflammatory marker, which should also be looked in open practice. So we did a study in our hospital based on the Ganga Hospital score and also the biochemical markers. Here you can see the treatment strategy was done based on the serum lactate and interleukin 6. And also the previous study compared without biochemical markers, our incidence of infection is much less when our treatment guidelines is based on the biochemical markers. Hence, to conclude, the open injuries from arrival to operation theatre, it is very important. Earlier transfer to a nearby trauma center, which has got a tertiary care, is very important. And all these injuries has to be evaluated as per the ATLS protocol. And documentation of the wound and sprinting of the fracture and dressing is to be done in the emergency room itself. And also the neurovascular examination is very important, and a good trauma series X-ray depicts all the regional injuries. And early administration of antibiotics has to be done in the emergency room itself. Thanks for your patient listening.
Thank you very much, Dr. Perumal. Very enlightening and a very sort of succinct talk. I've got a couple of questions to you. To start off, so one important take-home message I would like to highlight for the benefit of all the junior doctors who will be listening is that the use of WhatsApp and the use of clinical photographs. You said that you take the clinical photographs. What I found surprising is that you also said that you share the clinical photographs with the patient. Is that correct?
Yeah, we used to give in the file we used to give the pre-debridement photograph and
Right.
following a flap cover, and this photograph will be attached with the case sheet itself, the discharge
Yeah.
summary itself.
So this is absolutely good because the patient, after a period of while, maybe after a month or so, forgets the severity of the injury that they had actually come in. Because now the comparison with any complication or so is with the 1 day prior. They tend to forget how badly injured this thing was, the limb was. That's a very good take-home message. The second thing I wanted to ask you said you take a photograph and share it on a WhatsApp group. Do you take videos of that? I mean, what we have seen is that our residents, they take a quick video of a circumferential wound and take it in perspective and then put it on the WhatsApp group. So does that make any difference for you to arrange, or you have a standard protocol that, photo from the front, photo from the side, and photo from the bottom?
We take the front and side photographs.
That's it.
That's
Okay,
it.
with the whole limb in perspective. So basically,
Yeah.
the consultant surgeon should get an idea as to what he is getting into.
Because the consultant trauma surgeon will be in operation theater.
Yes.
So the resident who are in casualty will just send a photograph, means we'll have a fair idea how severe it is the injury.
Right.
So that we just have a look so that we can quickly shift the patient, and then we'll call the plastic surgeon also. We both will see the patient and talk to that.
Right. The next question actually regarding the wound photographs will probably I'll ask after the next talk, because it has a certain things to do with the debridement also. Because sometimes the severity of the open injury can be underestimated by juniors when they see a small puncture and they miss a moral level or a degloving that goes all the way up.
Exactly.
Yeah. The next question I wanted to ask you, you said the role of antibiotics and the choice of antibiotics was cefuroxime and aminoglycoside. And if there is a farmyard contamination, you add a metronidazole. Is that correct?
Yeah.
Yeah. Have you ever felt the need of not giving an aminoglycoside or so? Or have you tried your hand at just sticking with the first generation or second generation cephalosporin?
Yeah, because in grade 1 and grade 2 injuries, the Ganga Hospital group 1, we give only cefuroxime.
Okay. And you haven't had a chance to, or a reason to worry about it?
Yeah.
Okay.
So our aim is to debridement, and primary treatment at the earliest is better. So no need for amikacin.
Right. But administration of antibiotics is absolutely imperative, because you highlighted that you give the antibiotics. The first thing the patient comes in the casualty, he also receives the antibiotic along with the resuscitation.
Yeah.
Is that correct? Yes.
Yes.
So I think that's a very good point that the juniors must highlight, that more than the timing of debridement, it is also the dole to antibiotic time that is very crucial.
Yeah.
The third question I had, right now, this pertains to a very interesting topic which I'm interested in, is the inflammatory markers.
Yeah.
And you had a slide where you mentioned that you have divided into a pre-inflammatory marker era and a post-inflammatory marker era. Can you just highlight us on those? Two things I wanted to ask is, what is the cost of the IL-6 to the patient when you estimate? I mean, in terms of rupees, how much does it cost? Is it a very expensive investigation?
Not very expensive. It is less than 1,000 rupees.
Okay. And the serum lactates, anyways, you would get it into the ABG, isn't it? The ABG would give you serum lactates.
Not ABG, the serum lactate, directly measure of serum lactate.
Okay.
ABG,
So you can
take
directly
it from the arterial the route, but it can be taken in the regular venous blood. And when they take the open injury panel itself, we measure the serum lactate.
So the open injury panel would include, apart from the routine bloods, BUN, create, liver functions, it will also include a serum lactate taken
and interleukin-6.
Yes, and that will be taken from the venous blood. You don't require an arterial blood sample for that.
No need for an arterial.
Okay. And then as you have a cutoff mark in the serum lactates, about more than 4, less than 2.5. In interleukin-6, is there any cutoff mark that, this is bad news or this is not so bad news?
200.
It is 200
microgram per ml.
Okay, and to give our listeners a perspective, this 200 interleukin-6, would you expect a similar level in an elective orthopedic surgery? A post-op elective orthopedic surgery also has some inflammation. How bad is the interleukin-6 level in those surgeries as compared to open surgeries?
So there has been studies in joint replacements. Following a surgery, the level of interleukins, how it goes up and comes down. But in trauma is a different ball game.
Yes.
The moment the injury happens, the serum IL-6 level goes up.
Okay. Now, when you did your study about the inflammatory markers, did you also do it over a period of days? I mean, a day at presentation, 2 days, 3 days post-op?
So we do estimate serum lactate on arrival, both on arrival
Yeah.
And lactate we used to check in 2nd hour, 4th hour, 6th hour, 12th and 24 hours.
Right.
So it depends on when the lactates are very high, we give good amount of fluids and we check the lactates after 2 hours. Once it is coming down, trend is recorded, then we can go ahead for surgery.
Yeah.
And we document the IL-6 in the thing. We repeat after 6 hours, then only the level goes up.
Right.
Then we check at 12 hours and 24 hours.
So IL-6 you check 12 and 24 hours.
Yeah, 12 and 6, 12 and 24 hours.
Okay, so by that time you had made your decision whether you're going to give a definitive cover at the same time or you're going to delay the definitive cover.
The second definitive cover depends upon the biochemical markers. Usually serum lactate comes down in 6 hours time. Depends on IL-6 level. If it is less than 200 minutes, second or third day usually it comes down.
Okay. Okay.
Second or third day you can plan for a definitive surgery.
Okay, so I think we'll take these questions after Dr. Devendra's talk also, because certain a polytrauma situation and a mangled extremity is often a sort of evolving situation. I think Dr. Muthu wants to ask a question. Dr. Muthu, you can unmute yourself.
Ramesh.
Yes, sir.
We are in a peripheral center.
Yes, sir.
We used to give a lot of IV metronidazole before, that is for 5 years back. But unfortunately, I had 2 patients developed a severe anaphylactic reaction, maybe a bacterial contamination of the container, the packing. But I had a severe hectic time, almost resuscitated them with dopamine drip, and sometimes 2 patients had like that. Did you have anything with metronidazole? Actually, I'm afraid to do IV metronidazole now.
I have not come across any major allergic reactions with the metronidazole.
Thank you.
Okay, so if there are no questions further, I think we can move ahead to the next talk. Thank you very much, Dr. Perumal. Very enlightening talk and very good take-home messages to highlight regarding the documentation, the role of inflammatory markers, and the prophylactic role of antibiotics, and not to go overboard with antibiotics, because that is what we often see in patients who are managed elsewhere. They get all sorts of higher antibiotics when they are referred to a higher center. After this, I would welcome Dr. Devendra, who is a specialist trauma center again from Ganga Hospital, and who is going to speak to us on the use of scoring system to determine what happens next, whether you salvage and how you salvage. Over to you, Dr. Devendra.
Thank you, sir. Thank you for the invitation. Thank you, Ramesh, for an excellent lecture. Now I'm going to talk about the open injury severity scores, their use, and how we can use them in the decision making of salvage versus amputation. Whenever we come across these kind of open injuries to the casualty, question arises whether to salvage this limb or amputation is better to prevent poor outcome in the future. And there are various scores available in the literature which can predict the salvage, like mangled extremity severity score, limb salvage index, predictive salvage index, NISA, Hanover fracture scale, and OTA OFC open injury severity score. However, all the scores are designed to assess the open injuries who have, along with the open injury, there is a vascular injury as well. There is no score. All of them have a vascular component. None of them assesses the limb with open injury without any vascular component. So the Ganga Hospital open injury severity score was published to address especially the type 3A and type 3B open injuries without any vascular injury. And it was published in 2006. And our open injury severity score, it works on the principle of assessing the limb and patient separately, and the limb components like skin, muscle, bone, separately we assess. And in addition, we consider the patient systemic injuries and comorbid factors as well. So each component we assess from the severity of 1 to 5, skin and fascia, bone and joint injuries, muscles and nerves injuries, and comorbid conditions. All the other 3 each component gets evaluated from 1 to 5, and comorbid conditions we have to add 2 points for each condition. So these are the varying severity of injuries to the skin from no loss away from the fracture site to circumferential degloving. When the skin loss is, when there is no skin loss away from the fracture site, we score it as 1. Score 2 is over the fracture site without skin loss. Score 3 is when there is a skin loss away from the fracture site, and score 4 is when there is a skin loss over the fracture site, and circumferential skin degloving with loss is scored as 5. The same sequential way we scored for the muscle injury as well. Exposed tissues, partially injury where we can repair them, and irreparable loss of one compartment, subtotal amputation situation, we score them from 1 to 5. And bone injury also, a transverse or oblique fracture or a combination with less than 50% is scored as 1. And a combination with more than 50% is scored as 2. And a segmental combination or a periarticular injury is scored as 3. Bone loss less than 4 centimeters is scored as 4. And bone loss more than 4 centimeters is scored as 5. So, coming to the comorbid conditions, like the factors that influence the outcome are like injury to debridement interval. If it is more than 12 hours, we add 2 points. Sewage or organic contamination or farmyard injuries. And if the age is above 65 years, increased anesthetic risk, injury severity score more than 25 in a polytrauma situation, or if there is a fat embolism or persistent hypotension even after resuscitation, and if the patient presents with a major shock, or if there is another injury to the same limb like open tibia with same side distal femur or shaft femur injuries. All these problems gets 2 points added to the total score. So all the components of the limb and the comorbid factors are assessed separately and then combined together. Here, the individual score provides the guidelines in the treatment, and the total score helps to decide salvage and prognosticate the functional outcome of the open injuries. The total score, if the score is less than either 14 or below 14, we generally we can attempt to salvage those limbs. If the score is 17 and above, it is better to consider for amputation, considering the chances of ending up in poor outcomes. And 15 and 16 is a gray zone where the salvage or amputation is decided based on the multiple other factors like patient factors, surgeon factors, skill of the team, infrastructure availability, and all these factors are considered while deciding the salvage or amputation of the limb. When we compared our open injury severity score with MES score, both have got a very high sensitivity, and Ganga Hospital open injury severity has got a severity score has got a good specificity. However, the MES score has got very poor specific negative predictive value. So it is very important that we treat all the open injuries with a good experience. We should not use them to gain the experience. We have to treat them with a good sound experience. Even minor faults in decision making can lead to a secondary amputation, and firm guidelines and treatment protocols are necessary, which can be implemented from day one, from the time of arrival to the casualty. And failed salvages, salvaged but functionally useless limbs, and increased secondary amputations can be a burden to the society, patient, and it is economically, it is very burdening to the patient as well. So it is very critical for us to be able to predict successful salvage and ultimate functional outcome even at the time of the start of the treatment. So apart from the original publication in the 2006, we have again compared in the recent period all the scores, Ganga Hospital score, MES score, LSI, OTA, OFC score as well. And all of them are able to predict salvage very well. However, they are not able to predict which limb goes for amputation. And in that, Ganga Hospital scores very well and has a very good negative predictive value as well. So these are the wound management guidelines when there is a skin injury like 1 and 2, where there is no much skin loss. And if the total score is less than 9, if we are able to close the skin margins without any much tension with the bleeding margins, we can consider primary closure on day 1. And if the score is above 10, we can consider delayed suture if there is no skin loss. Sometimes we see there is a gross contamination, and still if the score is less than 10, we can still consider around 10, we can consider delayed suturing. When there is a skin loss and if the score is less than 9, early flap can be considered. And if the score is 10 and above, we can consider delayed flap. And if the score is skin score is 5, we need to use VAC therapy. VAC therapy can be used sometimes if we are not able to cover the wounds immediately. Assessment of the open injury wounds are very important, and it needs a good experience as well. Many times the moment fracture gets displaced, the wound appears to be large. However, the moment the fracture is aligned, once it brought to the length, good length, rotation and axis, actually we can appreciate that the skin can be closed without any much tension. So many of the open injuries which are considered as 3B injuries, actually they become 3A injuries because we are considering them for primary closure. So a score of 9 or less than 9, we can consider early management, early primary closure and early definitive fixation. And the score of 10 and above, we can consider for stage reconstructive procedures. These are the reconstructive pathways that we use in our institution: primary closure, delayed closure, soft tissue cover, and stage reconstruction procedures. Having seen the importance of open injury severity scores and how we can use them on a routine basis, let me show some of the cases. Here is a patient who had open injury of the leg. We can see that the initial wound appears to be grossly opened up, exposed tibia with a periosteum strip, and it is grossly deformed limb. However, the moment we brought to the length, actually we can see that the skin closure can be achieved without any much tension, and we can achieve good outcome without any infection. Here is a patient who had a bilateral open injury, a major crush injury of both lower limbs. Patient presented around 5 days later after initial management elsewhere. So both the open injuries of both the limbs were in the gray zone. Both the scores were 16 on either side. However, we considering the age of the patient and our excellent plastic surgery team, which can cover even the major soft tissue defects with the good flaps. So we went on to have salvage for both the limbs. The patient was referred to us considering the amputation on both sides. And here what we did was, we did a primary, on day 1 itself, we debrided on both the limbs. Adequacy of the debridement was very important. So we debrided adequately, and then the whole exposed bone was resected out, and primary LRS was applied on both sides, which can save our time for further reconstructive procedures. And subsequently, patient underwent multiple reconstructive procedures for soft tissue on both sides, and followed by corticotomy, distraction osteogenesis. And 2 years' time, we could complete the treatment, and patient is almost all returned to normal activities. So here, what made this possible is good resuscitation on day 1. Adequacy of the debridement is very important, and orthoplastic approach, involvement of plastic surgery team from day 1, which helps us to achieve adequate debridement level, and also plan for subsequent early soft tissue coverage. These factors helped us to achieve good outcome in those patients. Here is a 40-year-old gentleman, came in the middle of the night with right elbow and right lower limb injuries. This is a situation where grossly comminuted elbow with open injury is seen. Apart from that, there is a large skin degloving in the middle of the leg with grossly comminuted proximal tibia and distal femur. It is an open floating knee injury and open elbow injury, and lactate was 5 millimoles per liter. And however, no other systemic injuries. So what we considered was, here we tried to apply the external fixator for the lower limb initially, followed by debridement of the upper limb, And then in upper limb, we can choose primary definitive fixation in the form of screws and plates. In the lower limb, we can choose a damage control procedure, especially proximal tibia and distal femur level, so that we can plan for the reconstructive procedures in the later time. So this is how it was performed on the day one. After adequate debridement, we reconstructed the joints and then stabilized the bones with the plates. And subsequently, once the patient is fit for procedures, we went on to do reconstructive procedures. And this is the 3 years follow-up where all the fractures have healed after reconstructive procedures and patient is able to do all his activities. What made this possible was initial good resuscitation. Lactate was 5 millimoles per liter. So we chose good resuscitation followed by damage control procedures for lower limb and definitive procedures for the upper limb, and involvement of plastic surgery team from day one. And then we need to consider zone of injury very well. So floating knee injuries where the high velocity of injury is very high, the skin gets declawed completely from the underlying tibia. So it is always very important not to embark for reconstructive procedures quite early before the open injury is completely evident what is the level of actual injury. So here is a patient, 71 years old gentleman. He had a open injury and the score is 15. When there is a previous medical illness like this, myocardial infarction, elderly age, where he may not be able to sustain multiple reconstructive procedures, in those situations, we can consider amputation instead of salvage, because if you consider salvage, he may require multiple procedures and we might end up in poor result. And sometimes he may require secondary amputation. In considering all these factors, it is better to consider primary amputation, which can make this patient walk within 3 months' time. So if one wish to read about the initial management of open injuries, we have written a chapter in Rockwood and Green, 8th and 9th edition as well. And there is a score app available in Android, both Android version and Apple. So the score helps us to calculate the total score, and also it will help us to identify which patient will have good outcome, which patient will end up in poor outcome, and what are the probable requirement of a number of surgeries, and how many what is the length of hospital stay, and what will be the time to union by the time all the procedures are done and we achieve a union. All this information can be achieved if you type skin score, muscle score, and bone score along with comorbid score. You will get a total score along with treatment guidelines as well. Thank you.
Thank you very much, Dr. Devendra. Excellent talk as usual. Very good, very nice. And a lot of take-home messages for the juniors as well, especially the fact that, you can score it again after the debridement and the primary debridement is done. And yes, we in our center in the West Zone, I mean, we practice in Jupiter Hospital, which is a tertiary care center on a very busy national highway. And Dr. Abhijit Kale, my coordinator, he works in Sion Hospital. So at all these places, our residents do have the Ganga Hospital app on their phone, and they make very liberal use out of it.
Thank you, sir. Thank you.
Yes, it's a very, very good app, and I've mentioned it once before as well. Right. So having heard that, and if there are no further questions, I think we move on to next talk. And our next speaker is Dr. Kirubakaran Pattabiraman, and he's going to talk to us on management of open injuries and management of bone loss, something that orthopedic surgeon is challenged with once the limb is salvaged. Thank you very much, doctor. And you can start sharing your screen, sir.
Good evening, one and all. I'm Dr. Kirubakaran. I'm an assistant professor in Jipmer, Puducherry. I did my senior residency in AIMS, and I was introduced to this bone loss management by master technique by my professor Vivek Trika sir, and hence I'm showing some concept behind this Masquelet technique and cases operated using this concept. Bone loss.
Sir, can I sorry to interrupt you. We cannot see your screen. So if you can just do the same thing what you had done earlier on.
Am I visible now?
Sorry, you are visible, but your screen is not visible. Poonam, can you just guide Dr. Kirubakaran through this?
Okay, I will just log in through my phone.
Sir, you can try sharing your screen again.
I'm trying again. Am I visible now?
No, sir, we cannot see your screen.
Now?
Sir, don't do the full screen. Just see then if it is possible.
Yeah. Am I visible now?
No, sir.
No, sir.
So close your screen share and again share your screen, but don't do it full screen.
Okay. It's coming that my screen sharing is paused.
Here it's saying it started.
Shall I try and let him?
Meanwhile, I think the next speaker can speak, and I think I will.
He'll start it out.
No problem. So I invite Dr. Muthu, who is our next speaker, and he's going to talk to us about his innovative methods and local solutions for the problems which we face very commonly, especially in these open injuries, patients with bone loss, and places where there might not be any plastic surgery cover.
Am I visible?
Yes, sir. Yes, sir. Your blank slide is visible. So you can go to the next slide, sir. Yes,
Yeah.
sir. This is good. Yeah.
Thank you, the East Zone, West Zone President, the coordinators, and the entire team, our TNOA President. Thank you all, and good evening to all, and thank you for the opportunity. Just I am working in a peripheral small center, and just some practical tips in the open injuries and open fractures. I was the past TNY member. Now I am the vice president of Tanjore Ortho Club, and I had so many posts in IMA. And I take this opportunity to thank my teachers, Professor T.K. Shanmunathan, Sriram, Dr. Govardhan, Dr. Mail, and many others. So the primary objective in the management of open fractures is union with prevention and eradication of wound sepsis, as elaborated by the previous speakers very much. That is our aim, and being in a peripheral centers, I should make them 100%, I should give them 100% success rate. Otherwise, I have to refer them to some big centers. See, the most of it here will be road traffic, and other than that, we get some injuries from the villages, like fall, quarry, crowbar, paddy field injuries, cycle, bike accidents, cycle spoke injuries. As discussed and elaborated by the previous speakers, pain, shock, bleeding, fall of BP, other things, we should manage them properly. It was very well told by the previous speakers. Splinting with scales, kicks, and femur fractures, tying with opposite limb, usually I tell them in the 108 people. So never attempt to reduce the fracture before cleaning and debridement, that is from the casualty, because soft tissue will be subjected to further trauma, internal bleeding will be more. And somebody told the clamping should not be blindly done. Soiling and infection of bone chances are more. The excision antibiotic carried in the bloodstream will not reach the devices. Thorough debridement, dead and inert tissue or devoid of blood supply. All these things are discussed very much in the by the previous speakers. So in periphery, we see some fragments of clothing, wood, grass, mud, grease, oil. So all these things should be thoroughly removed, and from soft tissues and bone attachments. So this is the usual wound we see in the periphery, cycle spoke injuries. The child or the adult, they have a cycle spoke injuries. So we should have it is over the tender Achilles area where the healing is very, very poor. We should do a proper debridement, loose suturing. And edge trimming, all these discussed before. Careful replacing after surgical toilet. Cover the bone as much as possible. Surgeon who do not handle regularly open wounds, not to close the wound. It was the point as stressed by the Ganga people. When surgeon who are not having enough exposure with the open injuries, not to handle it. Otherwise, they will end up with all problems. So division of fascia, all this discussed before. Deep fascia to be divided freely, excision of crushed muscles, and the score, all discussed before. Tourniquet, as told by this, should not be used in the early phase of bone fixation. But once the tourniquet applied, they should record the time as stressed by the Ganga hospital people. Primary suturing, it is depending upon the plastic surgeons and neurosurgeons. So this is one of the bad injuries. Luckily, the patient did not have a fracture in the tibia. She had an entire degloving injury of the skin. I excised the skin, but I struggled a lot to get skin grafting. I have taken from all her the right thigh, left thigh, and other limbs, and she had a good function. This is also a runover injury by fracture, and she had a metatarsal bone fracture. I did debridement and primary skin grafting. She had a small soft tissue contracture of the plantar fascia that was with some foot chapels corrected it. And she had a bad open injury. It was the bike. Usually it is common in the bike. The foot will be caught in the bike and they will have a very bad open injury of the heel. So I did with the elixir of fixators and the later skin grafting. She had a good result. Suresh, he had a hit by bullock cart, bad open injury of the tibia and femur. So I did an external fixator for the tibia and skin grafting after 10 days. He had a good result. This is Ilayaraja had a open fracture of the femur, debridement, primary fixation, skin grafting at a later date. And the fracture united well. And this patient had a bad open injury of the forearm. So the wound debridement, K-wire fixation, and he had a good result. Some of the wounds, maybe a small wound, they will have a primary closure, because what I see usually when they go to some small hospitals, when they clean the wound, usually they will get bleeding. So the compounder or the doctors may be afraid of the bleeding. So usually they don't do much cleaning of the wound. You should get good bleeding of the wound. So otherwise you don't get good bleeding. You should not attempt a suture. Most of the wounds, they just clean it and suture it. So we do secondary suturing after thorough cleaning of the wound, especially in the fingers and in the forearm. Otherwise, deep infection you get, that is prevented. Open pus let out, cleaned again. These are all small problems we get in the periphery, but unless you attend properly the result will not be better. He had a small open wound. There was no bone injury. He applied some ointment like structures. He had a bad necrosis of the limb, and we did thorough debridement, skin grafting at a later date. We had good results. These are all small problems, but not attended properly in the peripheral centers. But once you do a proper job, you'll get good results. This patient had a open fracture of the tibia. I did fixator, skin grafting at a later date. Saravanan, open epiphyseal injury, distal part of the tibia. Open injury, the bone came out. I just put a fixator. The picture is not here. And I did collagen dressing for this fellow without skin grafting. He got a good result. These two patients I had like this. I worked in general surgery for 3 years before coming to orthopedics. So I had a chance to treat this fellow. I had, usually they will have a fall from height, some tin sheet, they will have an injury over tin sheets, just like that Kamal's Kalanger movie, you should have seen them. Somebody falling from height, they'll have a torn skin over the genitalia, the whole genitalia will be out. So I did a prime cleaning, and after 2 days, I did replantation of the testis over the side of the thigh and secondary skin grafting for the penis. He had a good result, and the sexual function also good. Open fractures of tibia. Actually, as told by Dr. Ashish, morning I listened to his speech on the trauma score, and he compared with arthroplasty and trauma surgeons. Trauma surgeons are doing very good job in India. He was telling, I just had his speech. So I don't have a team, a plastic surgeons team or a neurosurgeon team. So actually, I'm not doing much flap coverage. I release the skin from the posterior side. Most of these corticotomy, I started covering the open wounds without doing a flap cover or muscle flap cover. So I do debridement, splinting, third day corticotomy, distraction, skin grafting for raw areas after 7 to 12 days. Elizara, LRS I use for stabilization and distraction. This patient came to me after 10 or 15 days. There was LRS applied before. So I removed all the LRS and did a corticotomy, put a Elizaro system. The LRS with the infected bones, corticotomy, and the final union. This Palaniappan, it was a open wound. So I didn't do any flap cover, just corticotomy, distraction. After sufficient healing of the soft tissue area, I put skin grafting and no flap cover. Wound started healing, healed well. They had a final good union. So corticotomy, consolidating enough callus and clinically uniting. And corticotomy helps a lot in the revascularization. So this patient, I was not happy. He didn't come for proper follow-up. Actually, it was not a new injury. He had an open injury with bone loss. I just did a corticotomy and trying bone transport. He is on treatment, and I didn't get the final results. So this is just for a message. I'm doing 5 or 10 cases with the new stem cell treatment. Dr. Ravi in Trichy is helping a lot. This patient had a very bad open ulcer. Actually, I didn't have the preoperative picture. The whole raw area, I mean, the blanched skin was a big ulcer around 6 centimeters, 6 centimeters. I tried these stem cells for this man. I took 10 ml blood sent to the place, Trichy. They prepare some stem cell powder. We have to dilute it with normal saline, and I injected both sides, and almost 95% healed. And I am just trying with the 2 or 3 patients, even with the open injuries. I used to give a stem cells injection after some time, 15 days, 20 days, and they are getting good union, and I avoided bone graft in some of the patients also. So the message: thorough early wound debridement, excision of devitalized tissue properly and thoroughly, good stabilization with the KOH external fixation in children, femur later skin grafting, primary interlocking nail, early movement of the limb joints for better results. In open fractures of tibia, wound debridement, possible skin, soft tissue coverage, no flap cover I am doing. Corticotomy I am doing in 7th to 10th day, distraction, wound healing properly due to increased vascularity. Secondary skin grafting I do later. So, but whatever you do, we need some good luck and for our hard work for a good results. I thank my guru, Professor Shriram, Dr. Marthandam for this time, and I worked with them and learned a lot of techniques. So thank you all for the opportunity.
Thank you very much, sir.
I am working in a peripheral center. Originally it was a tall headquarters. Now it is becoming a district headquarters. When I started my practice 15 years back, most of the patients were referred. So I had these type of patients and I gave some good results.
Excellent, excellent. I think for our population where transport is a problem and people take a long time to come to the hospital itself, these solutions one should be very well aware of, and more so if we see that the results being delivered, it gives a lot of confidence to our colleagues who are also working in far off places where transportation is very fragile.
I refer only patients with vascular injuries. Other patients, according to the, as told by the Ganga Hospital, we used to manage them, except very bad injuries, more than that 15 score. Usually I used to manage them. Thank you.
But those cases also will be once in a while, isn't it? I mean, most of the cases that we would get is generally not as mangled as what we have been seeing in.
And we are not having a very, high velocity injuries here because we are in the small places. They don't have very state highways, national highways.
Yes.
Luckily, we have small velocity injuries.
Excellent, excellent. Very good, sir. Dr. Naveen Thakkar is here. He is the secretary of the Indian Orthopaedic Association, and would like to welcome Dr. Naveen Thakkar. Sir, good evening.
Good evening. Good evening to everybody. Good evening.
And we are
Sorry,
having a very.
I was late little bit.
Not a problem. So we are having a very interesting session, and we slightly changed the order because Dr. Kirubakaran had some issues sharing his screen. Okay. We finished a couple of talks from Ganga Hospital where good take-home points were there, like taking pictures of the wound so that you don't have to keep on opening the dressing again and again. Yes. With local antibiotic therapy depending on your own bacterial profile, and interesting points about doing the definitive cover using the serum lactates and the interleukin-6 levels. That I think is a good take home, and it can be easily implemented and replicated by surgeons all over.
Yes.
Poonam, if you're around, can you just help Dr. Kirubakaran through his presentation?
I think he tried to share and then it's not going on.
Yeah, so that happened a couple of times, but before the presentation he has shared.
Yes. Now it is there. Masquelet
yes,
technique.
Yes. Masquelet technique.
Am I visible now?
Yes, sir. Yes, sir.
Okay. Am I visible now?
Yeah. Everything
yes, sir.
is
Yes,
okay.
Sir.
Your voice is coming. Your slides are seen.
Yeah. Okay. So today Good evening to one and all. I would like to thank the IOA office bearers and the Western Zone office bearers and the Tamil Nadu Orthopaedic Association office bearers for giving me an opportunity to present on a difficult scenario which with respect to bone loss, defect management in limb reconstructive surgeries. There are two options available to the orthopedic surgeon with respect to gap management in bone loss. One is using Ilizaro distraction osteogenesis and Masquelet technique, which was propagated by Dr. Masquelet in 1986. It was initially it was done in sheeps, and it was demonstrated the proof of concept study, and later on it was executed in human beings in early 2000s, and the first surgery it was executed was to bridge a gap of defect of around 25 centimeters. And today we are going to just have a look out about the PLs and pitfalls of the Masquelet technique. We are going to see the basic the topics of history of Masquelet technique, the tips and tricks, and the way to make the spacer, and what the shape of the spacer, how to remove the spacer, and the cautions and the precautions to be done while using bone grafting in the second stage, and some case examples regarding to that. So there's the important concept of critical bone defect. So the in tibia and femur, the bone diameter is 2.5 centimeters. Any defect which is twice the length of the diameter of the diaphyseal shaft will not be amenable for primary cancellous or corticocancellous bone grafting. This is because of the fact that any defect which is tried to be bridged by primary bone grafting of more than 4 to 6 centimeters leads to graft resorption. Hence, this procedure was initially done with a cement PMMA spacer, polymethyl methacryl spacer, and any defect which is more than the critical bone defect of around 2.5 centimeters needs to be done using an antibiotic cement spacer or a bone transport. Yes, bone transport using Ilizaro or Nelaris is a very common procedure, and this procedure had a very it was done it had its own resistance to be taken up by the orthopedic surgeons, and slowly there are around 16 to 17 human case series and around 6 to 7 animal studies which is showing good results of Masquelet technique. So the theory which was the theory based on which this induced membrane theory works is the membrane which is formed around the cement spacer, which is kept in the bone defect, serves as a barrier against the inhibiting factors of the graft remodeling, and hence the graft remodels. Otherwise, the graft is resolved. There are three purported theories. The second theory is the cells within the membrane contribute to the bone formation and tropic factors that mediate graft remodeling. And the other theory is there is a rich vascular network around the vascular membrane that feeds the massive appetite which the graft remodeling needs, because if the graft remodeling is not given the cells nutrition, it needs to necrosis and resorption. Most of the basic prerequisite of this Masquelet technique is eradicate the cement spacer which we put in the Masquelet technique is not a substitute for debridement, as previously told by the experts. Thorough debridement is a mandatory prerequisite for this, and hence the failures reported by some previous series were due to the technique itself. And the induced membrane technique can be used only once, only if the infection is definitively eradicated. Sometimes healing of the infection means that we have to repeatedly debride the soft tissue and the bone with an external fixator. So vascularization of the membrane allows the healing of infection. This is not the case. So Dr. Masquelet gave the PLs and the pitfalls of why the Masquelet is working in some conditions. He has evolved his own techniques and he has addressed it, and he has specifically commented that most of his failures were due to technical mistakes, and hence there are now evolved techniques of using multiple devices within the space which is formed by the antibiotic spacer. So let's now go to how a spacer has to be used. The use of a cement spacer raises the problem of its components and shape. And he has advised not to use antibiotic loaded cement for 3 reasons. Because the antibiotic may be inactive on the germ and it's maybe leading to antibiotic resistance. Some antibiotics may affect the characteristics of the membrane, and absence of recurrent infection with cement without antibiotics is a sign of healing. So Dr. Masquelet's important point is not to use antibiotics, but the other papers like Dr. Peter V. Janadis says that if there is an infection, use the sensitive antibiotics in your antibiotic cement. Another common mistake is antibiotic loaded cement is capable. This is a controversial entity. Hence, debridement is mandatory, and antibiotic cement is not a substitute. And usually nowadays people try to make the surface of the antibiotic spacer rough so that the membrane is much more formed. So an irritative component from the cement like barium sulfate, which is a radiopaque product, it leads to membrane formation, better membrane formation. So membrane formation is a very important aspect, and hence we should be avoiding unnecessary antibiotic usage in the cement so that the membrane cellularity is not affected. The shape of the spacer is like there are 3 types of spacer which is available. The one is the most common is the cylindrical shape of, and the other one is the beads and the flat pebbles. So the tibia and the femur usually has a cylindrical cross section, and hence a cylindrical shape of the spacer is used in these conditions. These shapes are usually made before keeping it between the bone ends, and hence there are 2-3 tips and tricks on how to make a cylindrical bone spacer. So it should be as big as possible, and it should not be compromising the soft tissue and the skin closure. Very important tips with respect to the shape of the spacer is the spacer has to extend beyond the extremities, beyond the bone ends, and it has to overlap. So it has to during the solidification of this bone cement spacer, the soft tissues have to be protected by using a piece of glove and irrigating the spacer. The main pitfall is to put a cement spacer without wrapping the extremities, and it leads to the membrane ending at the edge of the bone end. So this may lead to poor incorporation of the bone graft with the parent bone and may lead to refracture. So cylindrical spacer is suitable for solid bones like tibia and femur. Usually the cement spacer is removed by just incising the membrane and hammering and using an osteotome. But for a smaller bone like clavicle, forearm, proximal humerus and distal humerus and hand and foot, the hammering can lead to the damage of the parent bone. So hence beads are used. So beads also can be used in atrophic non-unions and also in other spaces where the bone graft needs to be taken up and there needs to be eradication of, there needs to be formation of membrane for the bone graft to work well. So there is no observed difference between graft healing when a cylindrical spacer or beads are used. Flat pebble is used in a recalcitrant non-union without a defect. So the cement is placed around the site of the non-union to induce a cavity within which the bone grafts are later kept. So this is used in atrophic, recalcitrant and resistant non-union cases where even after bone grafting, the bone bridges are not being formed. So this is an example for a flat pebble and a bead. The flat pebble is kept on the posterior aspect of the humerus for helping the formation of the membrane in which the future graft will be placed. And this is an the bead which is kept on the medial side. fixation. The important aspect regarding the fixation about a bone defect which is managed by a Masquelet technique is it has to be rigid just after the second stage, but it has to become flexible later on to enhance corticalization. So an X-fix or a plate or a nail, everything, nail plate construct, all are possible. But the important thing is that the strain modulation across the graft has to be done, and the strain has to increase progressively across the defect and across the graft as the corticalization happens. So intramedullary devices, external fixation, all are used, and plates in principle cannot be used because but many of the authors have used plates successfully, but because you can't modulate the strain once the graft starts incorporating and there is corticalization of the graft. So the pitfall is a too rigid stabilization at the beginning, which is very good for to begin with for vascularizing the membrane. But once the graft is inside the membrane, it needs to be a flexible construct to ensure that the graft is incorporated with the parent bone. So when should the second stage be performed? The second stage is usually performed from 6 to 10 weeks. There are many literature evidences to suggest that delay in the second stage doesn't affect the membrane cellularity, and hence bone graft at the second stage can be considered as a foreign product that is likely to reactivate them, likely to reactivate the biological properties of the membrane, and the main role of which is to prevent the resorption of the graft. The main role of the membrane is to prevent the resorption of the bone graft. This I am reiterating because any defect which is less than twice the cortical diameter of these particular specific bone needs to can be primarily grafted without this technique, and only when it goes beyond the twice the cortical diameter, it needs to be used with a stage technique. Important thing regarding the interim period is we have to be meticulous with respect to the pin track care, and the surrounding soft tissue must have blood supply. This is very important because in a scenario with a compromised vascularity, this option cannot be offered to the patient. Only after the vascular status of the limb is ensured by either the parent vessels or by using a soft tissue flap or a free flap, the zone of injury needs to have adequate blood supply. This is the primary prerogative of the Masquelet to get succeeded. Antibiotics can be added to the sensitive if there is infection. This is a controversial entity because the Masquelet school of theory believes that antibiotics are not needed in the cement, and it's just the plain PMMA Homedica simplex cement would do. Whereas antibiotic added cement like the gentamicin or vancomycin can be added, but it should be sensitive to the. So this is an example for if you can see the right lower and the left lower picture, you can see the thick membrane in the about the spacer. So the infection is eradicated, the cement spacer is kept, and the membrane forms. So interim period, you maintain a external fixator and then graft it and then close it. So the important point regarding the grafts is the grafts must be morcellized, and it should be like a laddu, or you should be able to make it into a it should be morcellized properly. So the spacer must be exposed directly with. So what are the rules and what are the PLs and the pitfalls of removal of spacer? So the additional tissues must not be dissected. The incision over the membrane has to be very careful, and it has to be broken with a osteotomy and a hammer. The cavity is gently clean. Any non-viable tissue within the cavity is to be removed, and the medullary cavities has to be cleaned and curated before proceeding with bone grafting. Important point regarding bone grafting is the bone grafts has to be packed tightly within the cavity, and important thing is these bone grafts and then the membrane has to be closed. Once you close the membrane and make the patient bed bear with the X-fix, these grafts tend to unpack, and then due to gravity they may slide down, and hence the upper part of the space, the proximal part of the space, the graft tends to be not present, and it leads to failure in the proximal part of the gap. And hence, this has to be tightly packed, and there are multiple adjuvants to prevent the graft failure, regenerate failure in this Masquelet technique. So the samples has to be sent for culture, and the membranes must be incised with caution, and the non-vital tissues to be removed. The important thing is decortication. As Dr. Tanna used to say, shingling is a very important point. And here, this shingling, which is done at the end of the membrane, osteoperiosteal and osteocortical flap is elevated along with the membrane. And here the graft is also packed in addition to the graft which is packed within the gap. And this leads to a proper integration of the graft and prevents failure. So as you can see here, the grafts are overlapping the ends. So once if it overlaps the ends, it leads to a good outcome. So duration is not a matter. You can do it at 6 weeks, you can do it at 10 weeks, 2 months, 3 months, it doesn't matter. But the only point is it has to be done, and you have to make sure that the area is sterile. And you can do multiple cultures, you can repeat these cement spacers also. So gold standard is the graft choice for bone grafting. This spacer is cancellous bone harvested from the iliac crest, and corticocancellous bone is not advocated because it may lead to revascularization issues. And the cancellous bone graft must be less than 1 millimeters of cube. And if you are using allograft, the allograft should not exceed 1/3 of the total mass which you are putting. So allograft, or you can also use bone substitutes like TCP or hydroxyapatite. And the important thing is that it has to be placed very tightly, but it should not be crushed. The membrane should not be crushed. So the proximal part of the bone, the proximal part of the membrane bone junction has to be osteoperiosteally elevated, and the bone graft has to be included in that. So other graft choices include RAA or the cancellous autograft, or the biphasic grafts, which hydroxyapatite or beta tricalcium phosphate. Isolated cancellous allograft or bone graft substitute inside the membrane is not sufficient. So isolated allograft or isolated bone substitute is not a substitute for cancellous autograft. So you have to mix the biphasic hydroxyapatite beta TCP with the bone graft, or allograft with bone graft. So the personal experience of Masquelet was not to mix recombinant growth factor like the BMP which we get commercially with the bone graft, because it may lead to graft resorption. And to add fibula or not to add fibula. The point is, the fibula is being added in the Masquelet series only in one condition, where there is a knee fusion with the nail. The fibula is multiply perforated with multiple drill holes so that the vascularity encroaches into the fibula. So while the special situation refers to a big defect in tibia, usually in big defects in tibia, Dr. Masquelet specifically says that the cement spacer has to reach up to the fibula, and the grafts need to go up to the fibula so that a huge bone is formed, and a huge and the stability results. And hence the cement spacer has to reach up to the fibula, and hence the membrane forms from the fibula into the tibia and to the distal part of the tibia and the proximal part of the tibia. So important point, the important another point is drain is mandatory, because whenever you do a grafting up in the second stage, if the hematoma is not evacuated, this leads to graft resorption and may lead to the procedure failure, and hence drain is a very important part of this procedure. Weight bearing. Usually the bone graft which is placed within the space begins to corticalize in 4 months, and by 6 to 7 months weight bearing can be fully done. So this is an example for what we did in our trauma center, and this is a open fracture both bone leg for which flaps were done, and hence there was non-union, and subsequently we did a LRS with debridement, aggressive debridement and a cement spacer, and then we packed it with grafts. Subsequently it went on to unite, and the patient is weight bearing. So this is also a compound both bone leg fracture. There was a fasciocutaneous flap was done, and the time since injury was 7 months. And once the infection is eradicated, this can be done with the LRS. LRS offers the flexibility in strain modulation across the graft once the graft is corticalizing, and hence LRS is being preferred. And this is the graft filled in the membrane, and the graft being consolidating, and once the graft is consolidated, even if the proximal part, which is usually due to gravity doesn't consolidate, can be compressed across the graft, and hence it goes for a union. So this is a distal femur, which was a compound distal femur, which was initially managed with a fixator, and which was followed by plating. It was the time from injury was around 12 months. No flap was done, and hence the plate was removed. Aggressive debridement was done, and cement spacer. The advantage nail poses over the tibia, nail poses over a plate or an X fixer is the volume of graft needed for corticalizing and for bridging the defect is less, because the nail occupies the center part of the defect, and the nail diameter and the volume of the nail makes it that we don't need that much amount of graft, and the nail is kept inside the defect as the patient weight bears over the corticalizing or the consolidating graft, and then the graft nicely consolidates over the nail, and then the nail can be removed. So this is a open fracture distal femur, which was managed with a cement spacer, and a K-wire was kept, and plating was done once the infection was eradicated, and then grafting was done, and 9 months the grafting, there is a 3 cortex union. So even forearms can be done more masculine, even infected forearms, infected internal fixations can be done. So this is an example for an infected forearm being done with the Masquelet and a cement spacer, and it goes on to unevenly unite. So this is the trick which I told to do a cylindrical cement spacer. You can take a 10 ml or a 20 ml or 50 ml syringe, put the cement, put a K-wire, and then pull the cement spacer so that you can get a cylindrical. The important thing which advantage this it confers is the cement, the cannula and the plunger, the cement goes into the canal, and hence there is a better consolidation about the parent bone. So this is an example for the nail which is helping the Masquelet, but subsequently the nail breaks. So carbon nails can be used. This is a Masquelet which is used in infected calcaneum, a spacer, and the spacer here used is not a cement spacer but a calcium phosphate spacer. So people are using alternatives to PMMA spacer like calcium phosphate spacer, and infected maluniting calcaneum also can be managed by a Masquelet technique, where all the dead devitalized bone is removed, and a spanning K-wire and a cement spacer is put, and after removing the spacer you can arthrodesic. So here you are maintaining the calcaneum length and the bowler and the Gisens angle, so that the input mechanics and the ankle mechanics is not lost. The important innovation or the development with Masquelet is the use of cages. Once the bone graft is, once the cement spacer is put, you can use the cage to modulate the strain, and it prevents collapse, and the volume of graft needed also reduces considerably if you use a cage. So nails, yes, nails can have the propensity to break, but this is a complication. But there are many series to show that the nail assisted Masquelet is quite a successful procedure. And this is an example that you can also weight bear the patient more earlier compared to the plain Masquelet, which was done using plate or just X-fix. So fibrillar graft also can be used in these procedures, and they also tend to unite well. Unlike what Dr. Masquelet used to say, fibula is used only for femur. So there are like papers from Egypt to say, and Ilizaro is the bailout procedure when your Masquelet fails, and Ilizaro never. This is an option for a defect more than 4 to 6 centimeter up to 8 centimeter for the Masquelet to work. Beyond that, I think Ilizaro will be the best option. So a nail plate combination also works, and similarly, if you this works on the principle that the nail reduces the volume of graft needed and also helps in early weight bearing. And in this situation, you can see the cement spacer and the bone graft about the nail. This there is also progressive consolidation, 3-cortex union of the nail and the plate with the bone graft. So the complications are the refracture, graft resorption, failure to form the membrane, deformation of the regenerate, infections, hematoma, and hardware failure. I have shown you the failed hardware within the Masquelet, and also the hematoma has to be drained by using a drain, or then the infection, the superficial deep infections can occur if the initial debridement is not complete. The deformation of the regenerate is a problem which is done for a long defect. Failure to form the membrane, I will show you in the subsequent. This is an example for the proximal part of the defect which is not able to osseointegrate due to the gravity. And also when bone graft is combined with the bone morphogenic protein, it may lead to resorption of the graft. So this is an example for a regenerate going for a varus deformity, which was corrected later on by using a supramalleolar osteotomy. So this is an example for the graft. A patient. Previously I have shown a Masquelet which has failed over the nail. So it was like 3 procedures were done over the nail and the Masquelet, and it was investigated on each time by sending the membrane for histological examination. And it was found that the initial failure was due to the fact that the cellularity in the membrane was not adequate for the bone graft to osteointegrate. So, and hence bone graft, the failure to form a membrane can be identified if you send the membrane for histological examination in the before the second stage. So my references are the induced membrane JOT paper by Dr. Alan C. Masquelet in 2017, and the review article by Peter V. Giannidis in Masquelet technique for bone defects, and Orthopaedic Clinic of North America, Dr. Masquelet's review article. So these are my references. Questions are welcome. And I would like to thank my professor Vivek Trika and my HOD Dr. Gopi Shankar sir, and TNOA President Dr. Vanasekhar sir, and Dr. CG Ravi for giving me the opportunity to present my work, to present the work of our unit in AIMS Trauma Center.
Excellent presentation. Dr. Kirubakaran, excellent presentation. I was just trying to check if there are any questions coming up. But I think you just overwhelmed everyone with so much information that I think it leaves all the questions unanswered, including the problem which people have of the edges fracturing. The edges
people are more comfortable with the distraction osteogenesis and the LRS. This technique may be useful only because of the fact that the advantage is you don't need complex instrumentation. You can do it only with a plate, nail, and an X-fix. Yes. That's all. And a cement. You don't need a Ilizaro bone grafting. So the point is, in Ilizaro, it may take up to 18 months for the regenerate to consolidate. But here, within a year or so, the regenerate consolidates in all the follow-ups and in all the case series.
Right. So I don't think we are seeing any questions right now, but I think they'll put the questions in the chat box if there are any. And we come to the last part of our webinar today is an interesting case presentation by Dr. Naveen Thakkar. And Naveen sir, if you can share the screen.
Still time is remaining?
No, actually we have run out of time.
Then we can close it. I can present anytime, no problem. If everybody will be busy.
Yes, sir.
Tired of.
So
we'll present later on, no problem.
Yes, sir. So we invite Dr. Ravi Jaram, the Honorary Secretary of the Tamil Nadu Orthopaedic Association. He's here. He can give the closing remarks.
Dr. Ravi is here. Dr. Vanasekhar is here. President sir is there, but he has closed his both. But he must be
President
listening.
sir was there. He was there for some time.
He's joined,
Yeah.
connected. Dr. Vanasekhar, are you there?
Achha, nahi, it doesn't look like, sir. I think
Okay.
we can make the closing remarks, sir.
Okay. So we are very much thankful to all the contributors, those who have contributed to this webinar. And it was a very fruitful and detailed discussion about every cases. So very complex and complicated cases were presented with the new innovations of different methods of using, how to combat the infection and everything, and how to treat the open injuries. Once the Ganga Hospital consultants present, they have a large series and large experience with the different methods to implement these methods to treat the open injuries. So it's a premier institute where open injuries are treated maximally. And we have seen that the Ganga score is there with us with that reason. Thank you very much to all. Thank you, sir.
Thank you very much, sir.
Thank you, sir.
Thank you very much, Dr. Perumal. And thank you very much to all contributors from Tamil Nadu. On behalf of the West Zone, we thank you very much.
Thank you.
Thank you.
Thank you.
Yes, Dr. Vanasekhar has joined now.
Yeah. Thank you. I'm online, sir. Thank you.
Thank you.
So,
Thank you,
waiting
sir.
to receive you next week.
Yes,
Saturday.
yes. You are meeting
Yeah,
Saturday.
please.
Yes, yes.
Yeah.
yes.
Thank
Lovely.
you. Good night.
Thank you. Good night. Good night.
Thank you. Night.